Today's talk, I got the request to speak a little bit about anastomotic strictures and overall. And the pictures you see are pretty typical that we see on endoscopy when they start becoming symptomatic and we start going to endoscopy, or if we do a gastrographic enema. We don't do barium enemas anymore. So gastrographic enema, we see those pictures that you saw. So etiology on this, anything with strictures, it's not like one smoking gun, I say. It's multifactorial. It can be ischemia, which I think is the most important compounding factor. And the ischemia can be because of technical issues. We just did not, we sacrificed too much of the blood supply of the bowel connecting. But ischemia can be because of patient predisposing factors, such as smoking. And also very well described is that any of the low colorectal anastomosis that we protect with a diverting loop ileostomy, we allow for granulation tissue to accumulate. This area does not get challenged with volume and stool to keep it wide open. So a lot of our patients with protective stomas will start seeing that the colorectal anastomosis will start closing down. But with dilation, and after closing the protective stoma, we'll see that they will be reversed, easily reversed. And of course, we have blamed radiation. I don't know. I know radiation causes hypoxia, but I still, and it's considered like one of the complicated contributing factors. But radiation is for rectal cancer. Again, it's ischemia, not very good blood supply, and that really what will lead to stricturing disease. Interesting. I was looking at multiple reviews to see And this review and meta-analysis published in the Asian Journal of Surgery, they had all those factors, but they also included male sex. And if you think about it, I don't think it has to do anything with hormones. It's the narrow male pelvis, technically difficult to bring down the colon. I think a lot of times we cannot see as well. We may have sacrificed a little bit more mesentery than we wanted. And I think that's why we see that male sex is a contributing factor. It's just the pelvis is not as wide. It's not necessarily because of a hormonal issue. And Ferris has moved to the next slide, which is still on etiology. And I wanted to bring this up. There was a recent study in one of the journals that we consider our or our society journals of colorectal surgery journals in the U.S., the diseases of colon and rectum, where they did a cadaveric study on how we can decrease the chances for stricturing disease, increase the length, because you get ischemia when you really have very taut colon reaching down into the pelvis to perform the anastomosis. And I mean, it was not a surprise. I know it's a recent study, literally a year ago. They called in everything that we have learned since residency, like all of the surgeons in the audience. We all have learned how you need to sacrifice the IMA, sacrifice the IMV, take down the splenic flexure from the lateral attachments, and here you are. You have a much longer segment that will reach easily into the pelvis. The IMV, I don't care so much. I sacrifice it. Spleniflexor mobilization, you sacrifice it. The IMA, for most of the cancer cases, it gets sacrificed no matter what. Like all these techniques happen. I find the difficulty is when you have a patient that does not have any lengthening. So I'm worried, like when I mobilize and I still cannot reach, really my limiting factor is the middle colic artery is very short and there's nothing I can bring down to. So this is really the issue that happens. And then I have to make a decision if I can truly offer a coloanal or a very low colorectal anastomosis. I want to see that I'm not like really making taut my proximal colon. So again, etiology, and all of it is behind it will be ischemia. So in the same study that I mentioned in the Asian Journal of Surgery, they after they studied all the factors, they created a multivariate analysis and used logistic regression to create a predictive model. And in the predictive model, again, it doesn't tell you anything you don't know, but I thought it was smart when we meet with our patients and we talk about risks of surgery and what can happen after surgery, and if we're concerned about stricturing disease. In here, what do you see in the next slide, Ferris? You see on the right, I don't know how, it's small numbers, but really what they did is they found if you can preserve the left colic artery, less chances for stricturing disease. If you add a protective stoma, higher chances for stricturing disease. Goes without saying, if you had an anastomotic leak, everything kind of narrows down, becomes fibrotic and strictures. Anastomotic dehiscence, I don't know how you can save an anastomotic dehiscence and not go back into the operating room for a colostomy. But they added all those factors that they studied and they created like a predictive model that had, I think, about 70% a sensitivity and even higher specificity. And they use that model quite often just when they give their patients kind of the chances of when they are to develop the prediction if they are to develop anastomotic strictures. I have not used it with my patients, but I found it fascinating and maybe something I can have in mind when I talk to them. In the next slide, what I'm start talking now is like treatment. And I mentioned that the most common times that we see stricturing disease is very low colorectal anastomosis. What you see on the right is like literally the rectum coming all the way by the dente line. And again, I think it's ischemia. I think knowing the anatomy is key, particularly if it's not your surgical patient, it was not you who performed the operation and they come with this. Understanding the anatomy is key. And there are multiple ways you can achieve knowing the anatomy, doing your own flexible sigmoidoscopy in the clinic or a gastrographic enema. But when you have figured out the anatomy and it's very low, I do general dilations with the Hagar dilators that I have here in this slide. I have used them mostly for ilioanal anastomosis when we do J pouches for ulcerative colitic patients, not so much for colorectal anastomosis. But I have to say, I have used it also, and I know you'll have questions on Crohn's stricturing disease, on inflammatory bowel disease, where they can have a little bit of stricturing disease, not because of a necessarily of ischemia from surgery, but just as Crohn's disease that creates that fibrotic, takes away the muscle and creates like that wooden pipe that kind of closes down. So Hagar dilators, very carefully, of course, used. Something I do in clinic, and it doesn't require anesthesia or any other preparation. But goes without saying, and in the next slide, the fundamental core treatment for stricturing is endoscopic balloon dilatation. And if you go to the prior picture, Ferris, endoscopic balloon dilatation, you see here pictures, and I know we have few gastroenterologists that will describe it much better than I would ever be able to. You see the stricture, you place the wire, you go with your balloon, and usually they do about 15 millimeter pressure. I've seen them going a little bit higher, and by dilating it and then pulling it out, holding it there and then pulling it out, you can see how a stricture can be opened up. A study that I quote in the next slide had a large group of patients that underwent multiple balloon dilations. And you see that patients that may receive treatment and have to have dilated in the first year, they look at recurrences and they find out that the people that still have stricturing disease by year 5, but they do become less symptomatic and better with serial dilatations. Most of them resolve after 2 dilatations. But if you have somebody that is recurring and recurring, the success rate goes a little bit down of endoscopic balloons. But even at 5 years, which I found surprising, that they continue then endoscopic dilatations even up to year 5 without considering surgery, like to address the stricturing. They saw that most of the anastomotic stricturing did resolve even at year 5. And what they found is that predictions of one that who will need multiple dilatations is if you have as a luminal diameter less than a centimeter, and coloanal, again, very low anastomosis. But I don't think that needs so much balloon. I think you can easily do that with Hagar dilators and avoid the procedure in endoscopy unit. And of course, the one that needed more than 2, kind of predictive that they will need it. And I think it's chronic ischemia that closes the area down. Interesting enough, in the next slide, Ferris, I have not performed this. Oh, here is just, again, another pictures about the endoscopic balloon dilation. I'm not going to go so much over the technique, although I have quoted this paper and I took the figures from that particular paper because I know Saad, one of my colleagues, will be giving this lecture on how he places stents and how he does dilations. But it's for, and the slides, of course, can be shared with all of you who's interested. I thought they described a nice series there and how they perform the ADBs. Next slide, Ferris. The one that I find here fascinating, and I have to say, I've heard my gastroenterology colleagues doing it, is that when your balloon dilation is not enough, and you know you're dealing with a fibrotic now stricture, how comfortable do we feel cutting down into the fibrosis all the way where you see muscle? And you can use the needle tip cautery. And I've seen them doing it, but as you can imagine, you always become tachycardic because you don't want to cause a perforation. And when you're weakening the fibrosis, it's literally deciding on how things look, where the highest of scar is, to go and kind of do um, a scar incision. And in this particular picture, that's what it shows to us, how a scar incision. And that again, the issue I find here is the risk of perforation, that it will make me uncomfortable, although I know it's been done. The other thing is, anytime I do a local or rectal anastomosis, what before protected me from perforation, or I should say, it doesn't become a big clinical issue and it's more of a subclinical thing, is is the extraperitoneal versus intraperitoneal exposure of the intestine. When you sacrifice the anterior peritoneal reflection and you enter into that pelvis, into the TME plane, then everything becomes intraperitoneal. So a lot of this colorectal anastomosis that's so low, it's easy to perforate and have like an abdominal contamination and so forth. So something that I have to say makes me nervous, but definitely has been tried and has been supported by many papers. The next slide, what I wanted to bring up, apart from ECCI, which is the most common one, it's stents. And many stents you can use, either the very soft expandable, the esophageal stents that easily are used, the esophageal, which are short, it's for short strictures. The issue we have here with stents, and I have had some patients of ours receiving stents by our gastroenterologist to dilate and keep it open, it's the tenesmus. Our patients feel this pressure and it's extremely uncomfortable. They feel the pressure, they feel the constant pressure and need to go to the bathroom. And so I am not very keen on placing those stents. In that particular paper, that they had series of patients that they applied, stents, and it opened up and it was successful, and the patients did not need a reintervention or did not need surgery. But again, the issue of tenesmus, and a lot of those stents, when it's so low in the anastomosis is so low and you place a stent, with bowel movements, patients will pass the stent. So you have to repeat it so many times. So I'm not sure how keen I would be to have this as my long-term solution. But if it's a short term, keeping it and knowing that more likely that will be enough, and then just the frequency of bowel movements will keep a colorectal anastomosis open, I may give it a try. And I had a couple of patients, but I can tell you those stents don't last more than a week or 2 weeks. They get passed, so they through the anus. Now, when all those treatments happen, the stents, even the ECCI that I mentioned, the endoscopic balloon dilation, kind of old school, but it's been quoted in the literature, is inject steroids. So in the next slide, I think I have, with the treatment with the stents that I discussed, and I haven't personally done that, but it's been described, of like injecting 40 milligrams of triamcinolone across all the four quadrants, and that takes away the inflammation. Um, with a stent placement with endoscopic balloon here, at least at OHSU, we haven't applied also steroids. So the steroids treatment is more of an adjuvant, additive treatment when we go through the steps with endoscopic balloon dilatation or ECI. I don't think it's a bad idea. I just don't believe that it's a lot of inflammation per se, that's strictures. I think it's mostly ischemia. So I'm not sure how beneficial the steroids are. And if you're worried that steroids may make anything weaker, it may, I don't think it has been widespread use because of um, just think because of lack of support that it really is effective. What I found very interesting is in the next slide that it's been actually even brought up in one of our textbooks, and I found it interesting. that there is a technique that you can do without really doing a big abdominal exploration and redoing the anastomosis, just using the EA stapler. But if you think about it, in order for you to use the EA stapler cuts. So the bottom line is you're going to push it through and you're going to cut into the stricture, but you still need to fit in an EA stapler. So if somebody thinks that stricturing disease is less than 12 millimeters, an EA stapler is close to that. So it's interesting that that has been described, but a priori you think that the stricture is wider than 12 millimeters. So I'm not sure how much is a stricture truly if you can fit an EA stapler and employ this technique. With the next slide, something I have not done, but it makes sense if you have an ileoanal stricturing. Um, for the surgeons in the audience, all of us have done for Crohn's patients stricturoplasties, and the Mikulec-Heinecke is the one that comes to mind for short stricturing disease, where you make a longitudinal incision where your stricture is, and you close it transversely, so you open up the diameter. So what they describe here, and this was done on ileoanal as well as coloanal anastomosis that were closing down, and endoscopic balloon dilatation was not successful. They did stricturoplasties. So bottom line is you see the stricture, you go parallel to the stricture and you make longitudinal incisions, and then you cut out that stricture and you close it transversely. I have never tried that. I found it fascinating. I have to say, again, it would make me nervous for a perforation. And if I am to take a patient at that point to offer them something that I question if it's going to work, then I may probably bite the bullet, as I say, and go for the big operation. So, but I found it interesting. It was a very small number of patients and they showed success. So maybe something to be entertained. In the next slide, I describe what I do most of the time. I mean, EDBs, endoscopic balloon dilatation, so get me wrong, we use them all the time. It does work. It is the cornerstone treatment for anastomotic strictures. However, if that does not work after second, third time, then it's truly thinking about redo pelvic surgery. And most of the time, redo pelvic surgery, in order to take somebody, I have to think hard again. As I told you, like if I am to mobilize, I need to think of all my colonic lengthening techniques, because already I'm going to sacrifice the proximal colon to bring it down to anastomose. And in that, the middle colic is the limiting factor. Another technique that I've done a couple of times with Dr. Liu now, when everything fails and he cannot reach, I will mobilize the hepatic flexure, like literally the whole colon is free as much as possible and only held by its mesentery. And I will do the flipping technique where you literally flip the colon on itself, and sometimes that may give you length to reach down to the rectum. Um, Again, those big surgeries, I don't think it's um, an easy undertaking, not so much from the technical aspects, because we are in the abdomen all the time. And once that we do it all the time, we feel comfortable. But I have to say, it's something that you need to preemptively have long discussions with the patient, because you may not be successful and they may end up with an ankylostommy. So the patient needs to be aware that that may not be a successful attempt of redoing the colorectal anastomosis, and they, have to do, they have to get a permanent stoma. Again, it's I would do it for fit patients, like relatively healthy patients that fully understand the risks of the operation. And here I quote from a couple of papers: when you go ahead and you redo it so many times, your the continence of the patient may be an issue. Large lower anterior syndrome, anastomotic syndrome, like that is common. And I know we have a lecture about Lars that Dr. Herzig is going to be giving in the summer. But these are realities. It's not so much only the difficulty of the technique. I think it's the difficulty of the patient understanding all the functional complications you can have with redo pelvic surgery. Um, so in the next slide, what I have, and I know here I quote the SWAV procedure. I have to say, I've not done a SWAV procedure for adults. And I'm not a pediatric surgeon, but we did SWAV procedures when I was as a resident and trainee, very commonly done for pediatric patients. I have not performed them, but they have been described in the literature as an option for redo colorectal anastomosis. On the very end, what I have for you is a nice diagram of an algorithmic diagram, like with anastomotic strictures, what your options are. But bottom line, it really does depend on surgeons' judgment, surgeons' experience, patients' willingness to undergo a big operation with some gains, functional complications, and increased risks. Therefore, I would say that it's not for the faint in heart. But we do it. We do it all the time. We may do it minimally invasive or open surgery, but again, I mean, the functional issues that our patients face are real. So it definitely needs to have a very well educated and accepting patient before you take them for a big operation. But here, what you see in this a graph, it's, as I said, there is an algorithmic approach. Um, the TAMIS or the TM, I consider it kind of like redoing the anastomosis and suturing it. It's been described. I have not done a TAMIS to open it up because it's usually, if it's that low, you may have to be like, you may do like a, what I'd say, a pull through. That actually can be successful, but it's a coloanal anastomosis and the continence issues are significant. Like the patients describe a lot of particularly nighttime accidents. And that's one thing that I did not cover, but everything else we kind of discussed before of how we can address a colorectal anastomotic stricture. And I think with that, I've been speaking nonstop for 31 minutes and we don't have enough discussion. I'm going to end here and I am happy to answer any questions. And I think on the call, we may have other surgeons that can speak to it. Thank you. And I apologize, I'm on my phone. My computer is just not going to connect with a network.